Cool. Right, let's think what happens if you don't have access to food for a few days. Well, for a few, I get hungry after a few hours. Do you ever decide to fast for a couple of days?
Definitely not.
Yeah, I think I'll just fast for a while, and then I get hungry and have something to eat. It's hopeless. But if you don't eat for a while, then what will happen is all your glucose, the glucose in the blood, will constantly be used up. The glucose in your cells will be used up, and the amount of glucose in the blood is going to go down. So if you haven't eaten for a while, especially if you're using energy, well, you use energy all the time, but especially if you like working out or something, then the amount of glucose in the blood is going to go down. And that is detected primarily by the alpha cells. So these alpha cells here detect reduction in the level of blood glucose. So the beta cells were hyperglycemia detectors. The alpha cells are hypoglycemia detectors. They detect reductions in levels of blood sugar. And what the alpha cells do when they detect a reduction in the levels of glucose in the blood is they also release an endocrine hormone, but this one's called Glucagon. So the alpha cells release glucagon in response to a developing hypoglycemia when the blood sugar levels drop. So now, as well as not having a lot of sugar in the blood, you'll have glucagon in the blood. And glucagon is also an endocrine hormone, same as insulin. So it circulates around the body, and it circulates to... Actually, fortunately, remember yesterday when we had plenty of food? We produced a load of glycogen, didn't we? We didn't need it yesterday, but now we haven't any food, so the glucagon will act on this glycogen. Absolutely, yeah. Because it's produced by an endocrine gland, it's released into the blood, it circulates systemically all around the body, therefore it's an endocrine gland. So the key difference is an exocrine gland is released into a duct, like sweat. Sweat is an exocrine gland. Sweat is goes into a duct and goes onto the surface of the body. Or saliva is also an exocrine product. It's produced in salivary glands, goes out of ducts and goes into your mouth. It's exocrine.
Because is the pancreas exo and endocrine?
Absolutely.
Because of, sorry, John.
Yeah, the pancreas is exocrine. Yeah, the pancreas is exocrine because it produces digestive enzymes.
Yeah.
But it's also endocrine because it produces insulin and glucagon. And because the insulin and glucagon are not released into ducts, because they are released directly into the blood, they're classified as endocrine products. Endocrine hormones. So the glucagon will circulate to the liver, and the glucagon will circulate to the muscles. And what the glucagon will do is the glucagon will convert the glycogen, which was stored, the glucagon will convert the glycogen back into glucose.
What does glucagon look like?
What does what look like? The molecule?
Yeah.
Oh, it's just a small molecule. Let's well, the insulin was red, wasn't it? Let's make that one blue. So it circulates around in the blood. It's soluble and circulates around in the blood. So when the blood sugar levels drop, the lower blood sugar levels are detected by the alpha cells. They're the hypo detectors. The alpha cells respond by producing glucagon. The glucagon circulates from the pancreatic islets where it's produced by the alpha cells, circulates to the liver and muscles where the glycogen was stored, and it converts the glycogen back into glucose. So it's just the words, isn't it? They all sort of begin with G sort of thing, don't they, really? So glucagon converts glycogen back into glucose. Right? Glucagon converts glycogen back into glucose. Now, this is converted back into small individual glucose molecules. And because it's now converted back into small individual glucose molecules, because these are small, they're highly soluble. So they will go into the blood, and because now we have more small individual glucose molecules in the blood, what's going to happen to blood sugar levels? It's going to go up, isn't it? So the hypoglycemia has been corrected by the hyperglycemic effect of the glucagon. The glucagon is raising the blood sugar levels. Absolutely, yeah. Now we've got the individual glucose molecules, then as long as there's some insulin about, which there will be some insulin about, then those glucose molecules can go into the cell, be used by the mitochondria to produce energy. And that's important because that keeps you going until you can walk to a new food supply.
And they still use the same process of using that hole in the cell?
Yes. No, they can never do it on their own.
They always do that instantly?
Always.
With the insulin proteins?
Always, because the cell membranes are made of phospholipids and won't let the glucose molecules diffuse through.
Is that in all cells?
That's in the vast majority of cells. Actually, in brain cells, the glucose will go through pretty well on its own.
What's the cell membrane made out of?
Well, it's also phospholipids, but it's got a different nature, and it will allow some diffusion of glucose directly. So we see that the glucose has raised blood sugar levels. Now, you've probably got, I don't know, about 800 grams of glycogen in the body, something like that. You check this out lately, Tim. How much glycogen do you store in the body? About 800 mils, 800 grams?
I don't know.
Yeah, something like that. Probably about 800 grams. Anyway, you've got a certain amount of glycogen stored in the body. And depending on how much you're working out, you've probably got enough for a couple of days. So you can produce enough glucose, or you can liberate enough glucose from stored glycogen to maintain your energy levels for a couple of days. And this is actually quite good clinically, because if someone's hypoglycemic, can you see one way we could treat that is to give them something to eat, isn't it? We could give them a Mars bar or something. We give them something to eat. Or we could give them a drink of Coke or Lucozade. All these things contain huge amounts of sugar. But if someone's unconscious because they're hypoglycemic, so if someone's hypoglycemic, they'll probably become confused first, then they'll become unconscious, and at some point after that they're at risk of dying. So can we give unconscious patients drinks of Lucozade? No, because it will go down into the trachea. That causes a condition called aspiration pneumonia, which is, that always kills you, pretty well always kills you. So you can see if a patient's unconscious, we can't do that. Now that's fine in hospital. We can put a intravenous line in and we can run some dextrose solution directly into their bloodstream. We can give some intravenous glucose, or dextrose we would normally give intravenous sugar. But if someone has a hypo in the car park, you probably haven't got a drip on you, have you? Or cannula on you, or some intravenous dextrose on you. So what diabetics often carry is they'll carry a little injection which we give intramuscularly of glucagon. So if someone's hypo, you can give them an intramuscular injection of glucagon, which is easy, and that can be enough to wake them up. That will release enough sugar from stored glycogen to wake them up. And then when they're awake, then we can give them something to eat, can't we? And get back to normal after that way. If someone's hypoglycemic, right, and they're unable to eat, and we can't give them intravenous sugars because we're not in hospital, then we can give them intramuscular injections of glucagon. Glucagon. And the glucagon will increase the blood sugar levels, wake them up so we can give them something to eat. Now, suppose we're in a really difficult time and we haven't found any fruit or vegetables and we haven't had any antelopes killed by the tribe for a few days and we haven't eaten for 2, 3, 4 days. Can you see we're going to run out of stored glycogen? Does that make sense? We're going to run out of stored glycogen. But we need a certain amount of glucose in the blood. Otherwise, the brain's not going to work. Otherwise, the brain's going to die, isn't it? So we're okay for a couple of days. That's fine. But if we don't have food for longer, then we've got a problem. But fortunately, I can find the wardrobe. Fortunately, what have we got in here? No, over here, underneath your right costal margin. Yeah. Remember, your liver's underneath your right costal margin, isn't it? It's under there. What's at the top of the tummy on the left-hand side, top of the abdomen on the left-hand side? That's the spleen, isn't it? So it's liver there, spleen there, head, body, tail of the pancreas there. So you've got your liver under there. So what will happen in this situation, if we haven't eaten for a few days, is, there's your liver. The glucagon will go to the liver. So the glucagon goes to the liver. And one of the things the glucagon will do.
John, I hate to be here, but you've confused me. You put an arrow on the glycogen, but you're talking about glucagon.
Quite right.
Glucagon. I keep calling it glucagon.
Very astute. Glucagon. No, quite right. Actually, glucagon there.
I'm just so confused with the words there.
Yeah, I know. So the glucagon goes to the liver. And what happens is the glucagon stimulates a process called gluconeogenesis. Gluconeogenesis. Gluco means glucose. Neo means new. And genesis means beginning. So the glucagon can actually make a certain amount of glucose by breaking down fats and proteins. It's not a brilliantly efficient process, it's a bit slow, but the gluconeogenesis can use fats and proteins to make more glucose. So initially, the glucagon will maintain blood sugar levels by breaking down glycogen.
In the liver.
It breaks down the glycogen from the liver and the muscles.
Yeah.
But because you only store so much, but if there's still no food after 2, 3, 4 days, then the glucagon will stimulate the liver to make glucose, but it will make it from fats and proteins using this process called gluconeogenesis. So can you see that means that the glucagon is still raising blood sugar levels days after the last time we've eaten? Yeah.
Is that the same thing as ketosis?
No. Good question. If someone hasn't eaten for a few days and you smell the breath, it smells sweet because it contains something called acetone. And acetone is one of what we call ketone bodies. So if someone hasn't eaten for a while, as well as making a certain amount of new sugar from gluconeogenesis to keep the brain going, the glucagon will actually also stimulate the liver to produce ketones.
Is that why you look for ketones in your hair?
Yeah, ketones, it will produce ketones. So ketones are this smelly acetone type stuff, plus ketones, there's 2 acids, 2 organic acids in ketones, but they are energy rich acids, they can be used as a fuel supply. So in starvation, the glucagon will maintain blood sugar levels for weeks by converting stored fats and proteins to glucose. That's gluconeogenesis. But also the glucagon will stimulate the liver to produce ketones. It's ketones that gives that acetone type smell, but ketones are also used for energy. And we can run on ketones as our energy supply until we run out of fats to make the ketones from. Yeah.
Is that why some people take ketones? Because it burns the fat? Is it like
Well, you can't take
raspberry ketones?
Yeah, you can.
They're not ketones, they're raspberry ketones, that's just...
No, you can't eat ketones.
But it's just a rip-off concept.
Yeah.
Not actual ketones.
Yeah, I don't think you can eat ketone. I've never heard of it. Yeah.
Are ketones a byproduct of fat then?
Yeah, right. So if you've no access to food, the glucagon will go to the liver. The liver will convert fats into ketones. So when someone is hungry, lots of ketones are going to be released from the liver into the blood. And the ketones can be used by most cells as an energy supply.
Why do we look for that in your urine sample then?
Right. Well, if someone's got ketones in their blood, then those ketones will leak out of the kidneys in the urine. So ketones in the blood, ketonemia will result in ketonuria. You'll get ketones in the blood. And what that means, if someone's got ketones, that means the glucagon has stimulated the liver to make the ketones, but that will only happen if the blood sugar's been low for a long period of time.
So is that one of the signs to find a diabetic? Like
Yeah.
type 4?
Well, yeah. So one thing it might mean is the patient is hungry because they haven't eaten for a long period of time. So in starvation you'll get a ketosis. But also, if you remember, I think I've rubbed it off now, but remember if we had this cell, when we have a cell, there's the cell, there's the mitochondria inside. Now, if there is, if someone's starving, right? They're starving, then there's no sugar to get into the mitochondria, and in the liver, that means that the liver cells will start producing ketones because there's no glucose inside the cell. But also remember, in type 1 diabetes, for the glucose to get into the cell, we've got the insulin receptor, but we have to have the insulin. It's only when we've got the insulin and the insulin receptor that the glucose is going to be gated into the cell. So if there's no glucose, because someone's got type 2 diabetes, if there's no glucose, can you see, as far as the mitochondria is concerned, the situation is exactly the same. It can't make, it's not getting any glucose. So the liver cells, if they're not getting any glucose, they're going to respond by producing ketones. So that's the irony of diabetes. You've got loads and loads of sugar molecules outside. In this case, outside your liver cell. Millions of those. But because they can't get through the membrane, then as far as the mitochondria inside the liver cells are concerned, this patient is starving. They're not getting any glucose. So the mitochondria in the liver cells won't get glucose if the patient is fasted or starving, but also, and therefore will produce ketones, but also if the patient has type 1 diabetes, there's no insulin getting through, therefore the glucose outside the cell can't get in, therefore the mitochondria in the liver don't have any glucose, and when they don't have any glucose, they start producing lots of ketones.
So if both type 1 and type 2, then ketones will be produced?
No. Ketones are produced primarily in type 1 diabetes. Yeah. Now, in type 2 diabetes, the reason is that type 1 diabetes is an absolute deficiency of insulin. You get no insulin at all. And if you've got no insulin at all, then you're going to get ketone formation. But in type 2 diabetes, the amount of insulin might be reduced, but you've always got a little bit of insulin. And the thinking is that in most cases of type 2 diabetes, there's enough insulin to prevent ketone formation, just. Having said that, very rarely some type 2 diabetics might get a bit of ketosis. But basically, if we find ketones, that means it's type 1. So a good way, if a patient's admitted with diabetes, we just test the urine for ketones, and if there's ketones, then you're pretty safe in saying that's a type 1 diabetes. If there's no ketones but the patient's still hyperglycemic, then that will be a type 2 diabetes.
This might be a little bit further ahead, but if you can fix the problem with insulin, why is it that some people think that if you're insulin dependent for a long time, it can seriously prolong increase your risk of dying at a younger age? If you're able to fix it like that, why would...
Fix what?
If you can sort of keep the blood sugar under control at the homeostatic.
Oh, right. Right, so what you're saying is that diabetes is caused by insulin deficiency. And if we give insulin, why doesn't that cure everything?
No, what I'm saying was, why is it that some people believe that type 1 diabetes can cause you to die a lot younger because you're taking insulin, when if you're keeping it at that homeostatic level?
Okay, yeah.
Why would it make a big difference?
Right, if people develop type 1 diabetes and insulin is not available, then they will die within months. They'll die quickly. They'll die from the short-term complications of type 1. But if we give the insulin, then they won't die from acute hyperglycemia and ketosis. They won't die from ketoacidosis. And hopefully they'll be well for many decades. But people with type 1 diabetes do have a shorter life expectancy than people without diabetes. And the reason for that is primarily they get diseases of their blood vessels. And they get diseases of the blood vessels that go to the heart and the brain. So they're more prone to coronary arterial disease and cerebrovascular disease. But they also get other complications like infections, damage to their peripheral nerves, and damage to their kidneys. So the most common cause of kidney failure in the UK at the moment is in fact diabetes. So the answer is they get long-term complications of diabetes more frequently than other people.
Is that why they're reluctant to give type 2 diabetes insulin?
The average at the UK at the moment is that after someone's been diagnosed with type 2 diabetes, they typically need insulin about 7 years after their diagnosis. So I wouldn't say we're reluctant, we give it when we need to. Cool. Right, can you see we've done homeostasis? We've done what happens if the blood sugar level goes too high, the insulin is produced. If the blood sugar level goes too low, the glucagon's produced. In the short term, the glucagon will liberate glycogen to maintain blood sugar levels. When the glycogen's used up, the glucagon will stimulate the liver to produce some fresh glucose, some new glucose, in this process called gluconeogenesis. But longer term, the glucagon will also stimulate the liver to produce ketones. And the ketones will keep you alive as long as you've got some fats to utilise. So if someone's really quite obese, in fact there was someone once, I wouldn't try this, but there was someone who was remarkably obese, and some nurses got hold of him. They put him in a room, basically put him to bed because he was morbidly obese. And they gave him lots to drink and they gave him vitamins and they didn't feed him for a whole year. Unbelievable. And he didn't die. We wouldn't recommend that really, but he had a year's supply of energy. He must have been massively obese. But for most people, most average people can live. How long do you think you can live without eating at all?
3 months.
What we sound did 54 days.
Yeah, it depends how much fat you've got, and it also depends how much muscle you've got, because the muscle's broken down to make energy as well. I'd say most of you would be feeling pretty rough after 60 days of not eating. Yeah, you probably died about 60 days. Yeah, about 60 days. Shh. Hang on, one more, just a minute, a couple of questions, then we'll have a chat. Yeah, go on.
What about drinking? How long can you hold that?
Well, it depends how much water you're using. If it's a hot environment, you can die within 48 hours. If someone locked us in this room now, we'd probably last for about a week. So it depends how much is going out. It's an energy balance thing, isn't it? Now, children, of course, are going to run out of energy much quicker than adults. So neonates don't have a lot of fat storage typically. So babies need fed pretty well straight away after they're born. And throughout childhood, most children are actually quite thin. They don't have a lot of spare adipose tissue. So children need fed on a much more regular basis and can get malnutrition really quite quickly. They can get protein energy malnutrition, and they can get particular types of malnutrition due to deficiency of specific nutrients as well. And of course children are more prone to dehydration as well because they've got lower blood volumes, haven't they? Good. Right, do you want to explain glucagon mechanisms to each other?